So it sounds like we have a 30-year-old female with a head injury popping.
The Shock Trauma Center started with Dr. R. Adams Cowley, a pioneer in open-heart surgery. Early in his career as a U.S. Army surgeon in post-World War II Europe, Cowley learned that speed can save lives in the battle against shock. In 1961, with an Army grant to study shock, Cowley set up the first clinical shock trauma unit in the nation, a modest 2-bed facility later expanding to 4. Cowley's intensive patient monitoring and treatment led him to develop the golden hour concept, the period of 60 minutes or less following injury when immediate definitive care is crucial to a trauma patient's survival. Cowley also concluded that pre-hospital care is critical to the success of the golden hour. Pre-hospital care entered a new phase in 1970 with the first medical evacuation, as a Maryland State Police helicopter with an onboard medic provided a patient with speedy transport and simultaneous medical care along the way. A 1971 car crash in Frederick was pivotal in forming today's emergency medical system. The critically injured patient was a member of then-Governor Marvin Mandel's staff. The patient had a time-sensitive injury, prompting Cowley to have the man flown to Baltimore by helicopter to increase his chance of survival. The strategy worked, and the patient survived. During the patient's recovery, Governor Mandel observed the life-saving work of the shock trauma unit and the evolving trauma and EMS system that Cowley was developing. In 1973, Mandel issued an executive order creating what's now known as the Maryland Institute for Emergency Medical Services Systems, or MIEMS. The system included EMS field operations, the R. Adams Cowley Shock Trauma Center, and a research arm called the National Study Center for Trauma and Emergency Medical Systems. The system grew with increased patient volume, prompting the need for a separate, dedicated shock trauma center. The nation's first standalone, fully integrated trauma center opened its doors in 1989 in Baltimore. The facility was expanded in 2013 with the addition of a critical care tower. Today, shock trauma provides evidence-based treatment as Maryland's primary adult resource center for patients with life-threatening and time-sensitive injury and illness, as well as the state's referral center for head and spinal injuries and hyperbaric medicine. More on these specialties later, but first. A patient's arrival at shock trauma, either by land or air, triggers a series of steps designed to get the patient to the next phase of treatment efficiently and effectively. Medevac patients land on the roof of the trauma center, where an admitting nurse and technician meet the flight crew and patient to take them via special elevators to the Trauma Resuscitation Unit, or TRU, on the second floor. Patients arriving by land use the same elevators. At the TRU, the trauma team quickly evaluates patients for injuries. Each patient receives a battery of tests within the first 15 minutes of arrival. Assessment and intervention in the TRU follow the same life-saving guidelines as EMS procedures in the field: airway, breathing, circulation, disability, and exposure, or ABCDE. There are 13 trauma bays in the TRU, CT scanners capable of taking images from all angles, and a radiology reading room, all co-located. The TRU has its own blood bank for patients who need quick access to blood products. Communication is key to the successful transfer of patient care between the EMS team and shock trauma. SysCom, the Systems Communication Center, connects pre-hospital providers to several hospitals, including the trauma center, to share information and patient consultation. A nurse speaks directly with EMS providers via phone. Providers can also request a trauma line consult for medical advice from a trauma attending physician. Patient information prior to admission is visible in the TRU, but a physician can be anywhere in the trauma center and may be engaged in patient care. Okay. Information from the field must be clear and concise to simplify decision-making. Shock Trauma's facilities include an EMS room for providers. It's equipped with computers and telephones to complete required paperwork. Secure storage cages for EMS backboards and equipment left after transport are available for each of the 5 MIEMS regions, accessible through the security booth at the ambulance entrance. Here's a quick tour of what shock trauma offers for patients. The hyperbaric oxygen chamber on the ground floor can treat up to 23 seated patients or 10 on stretchers at the same time. The chamber is used for a wide range of patient conditions: carbon monoxide poisoning, smoke inhalation, crash injury, acute traumatic ischemia, air embolism, decompression illness, compromised skin grafts, radiation tissue damage, and necrotizing infections. Patients with inhalational burns can also be treated in the hyperbaric chamber, but it's important to note that the state's burn centers are the appropriate referral facilities for patients with burn-related injuries. A multidisciplinary team at Shock Trauma's Neurotrauma Center focuses on patients with injuries to the brain, spinal column, and spinal cord. This approach ensures immediate diagnostic and therapeutic access while providing a variety of follow-up services, from respiratory and physical therapy to case management and substance abuse programs. Shock Trauma has 10 state-of-the-art operating rooms, 12 post-anesthesia recovery beds, and dozens of intensive, intermediate, and acute care beds. Conditions treated include thoracic, intra-abdominal, and facial trauma, as well as complex orthopedic injury, life-threatening respiratory failure, multiple organ dysfunction, and sepsis. Patients benefit from sophisticated monitoring and bedside clinical computer capability. Shock Trauma's expertise extends beyond its walls. A specially trained rescue team can be called to the scene in cases where it may take more than an hour to extract a victim. The GO team members, including an attending physician and a certified registered nurse anesthetist, are trained in field surgical care and state EMS protocols. They work closely with on-scene emergency medical and rescue personnel to provide patient care. Pre-hospital education provides training both inside and outside of shock trauma on a variety of topics. And to help understand the relationship between pre-hospital procedures and definitive hospital treatment, EMS providers can accompany trauma nurses for 8-hour shifts in 2 different clinical settings.
RC, EMRC, City Medical.
You can hang up if you want, but I'm still going to talk about what the plan would you rather?
This is a place dedicated to saving lives. This is where my life was saved.